USC School of Medicine and Professor Emerita of Geriatric Psychiatry at the University of Washington. Welcome to this event titled Case Conversations in the Timely Recognition of Alzheimer's Disease, a Social Media Experience. Joining me today are Andrea Gilmore-Bykovskyi, Associate Professor at the University of Wisconsin in Madison, and Mary Norman, geriatrician at Cedars-Sinai Medical Group in Southern California. Welcome.
Hello.
Thanks, Sue.
Good to see you. Welcome, everybody.
Today, we're going to be talking about the value of early and timely diagnosis of cognitive impairment and how we go about it. But first, what do we really mean by early and timely? Early and timely for whom? Maria, Andrea, your thoughts?
Early for me means as soon as possible, whenever you detect any changes in your cognition or behavior. We know that the earlier we detect, the more impact we can make, and we can delay onset of cognitive decline. A lot of things for me is the most common questions I get is what's normal and what's not. So starting that conversation early on in our partnership with our patients and families.
I totally agree. I also think about early chronologically in the disease course a lot. You know, early means we're catching things, perhaps at very subtle changes in cognition. And I think of timely really as, a person and family-centered responsiveness of our system and our willingness to follow up promptly when something's concerning. And timely and early ideally line up. And sometimes they don't.
Mm-hmm. Yeah, so when I think about this, I think about the fact that cognitive disorders so often are associated with crises for family, crises for clinicians, crises for healthcare systems. And really early and timely diagnosis for me always has to refer to the issue of crisis reduction or crisis prevention. So in a lot of ways, our clinical goal is to prevent crises from happening that are the result really of undetected, unmanaged cognitive disorders. So Mary, I know you agree with this point of view, that it's the starting point for proactive patient management. You want to give us a little bit more detail about that?
Absolutely. I think one of the big goals of our work here is to normalize cognitive changes. We want to recognize what's normal with cognitive changes as we age, but we also want to make our family members, our fellow clinicians, our patients aware of what represents something that's atypical, that's not within the normal course of changes. And when we do this, if we normalize it and it's part of your annual discussion with your physician, then we can really start to look at things that might be modifiable. Looking at sensory changes, seeing and hearing, making sure we're maximizing those, looking at our medications and taking away anything that may be causing some cognitive changes, looking at sleep patterns, mood, alcohol use, exercise, diet. And so it opens up the conversation where people may think, I don't want to bring it up because I don't think there's anything the medicine can offer me, to, hey, there's a lot we can do to modify how well our brain ages. And also the ability to plan for the future, to be able to document your advanced directives, make your financial planning, so that we can honor you. My number one job as a clinician is to honor my patient. And if I don't ask about what their goals are, there's no way I can accomplish that. And now there's even more opportunities to participate in research. If you recognize there's some cognitive change, you may be eligible to participate in research. Now there's even disease-modifying agents if you're diagnosed with very early on Alzheimer's disease, for instance. So much hope if we recognize and address.
So I see that there's a question in the chat asking about eligibility, referring to this question or this possibility of identifying people who may be eligible for disease-modifying treatments and other care strategies. Any comments about that?
I mean, I think that eligibility requires that we focus on early.
Yeah.
We've got to really be looking for even subtle changes. These might be presentations that come on with behavioral or personality changes. It may not be overt, and really before some of the functional impacts as well. So that's an important component for eligibility, as well as what's available in their specific health system and network, because of the monitoring that's required for some of these new therapies as well.
So one other perspective is that there are things that we can do to help people. In fact, I was recently asked, why do I care so much about this issue? And why am I so committed to improving care for people with dementia? And it's because there's so much we can do for them. And that's quite separate from the question of disease-modifying therapeutics for very early stage Alzheimer's disease. People with cognitive impairment, no matter what the cause, there is a lot that we can do as clinicians to help reduce the suffering that goes with this for patients and families. And let's keep our minds on that too, that it's not just the very early cases of Alzheimer's disease, but it's everybody with a cognitive disorder, and our potential to help them with non-pharmacological interventions, with healthcare delivery interventions and innovations. So now let's turn to our cases.
I was going to add, I agree so much. And, one other way that I think about this is it's also the consequences of not doing those things. Mm-hmm. And some of these are consequences to the patient, but also to their family. And some of these consequences are intergenerational. Mm-hmm. The financial impacts of us not doing the things that we can do that alleviate the burden of dementia and how it impacts people's lives and their families' lives, don't just affect here and now. They can affect families for 1 or 2 generations if they're not able to do, as Mary mentioned, this financial planning, this estate planning. So I think the impacts are wide-reaching.
That's a really, really good point. And maybe we can keep that in mind as we work through the cases that we're presenting today. Mary, you have a case for us.
I do. I'm going to share one of my favorite annual wellness visit experiences. This is a 72-year-old woman with history of hypertension and some mild prediabetes, some sleep apnea, and she comes in for her annual wellness visit. As part of that experience, we do a screening mini-cog, which is what we use as our screening tool during our annual wellness visit. And she does really well out of that. 3 out of 3 on the short-term recall. Her clock is perfect. But she's very concerned. She's noticing some changes. She feels like she can't find her words as easily. She's slower in responses. She can't remember the TV show that she saw last week. And she's really concerned about the changes that she's seeing in herself. It's definitely a change from what she views as her baseline. So I'll throw that out for discussion for our group. And first is at this point, she screened negative. Everything else looked okay. I've controlled her other disease. Should we go on to do any further assessment?
Andrea, what do you think about that?
Well, this sounds like a case that makes me think about opportunities to partner with neurology and with other specialists. I do think that it's so important when we hear these concerns, however subjective they are, and whether or not they are lining up with what we're seeing on these cognitive screeners, that's really, in my view, that's step 1. And I think my thought is we need to bring this person along to step 2 and step 3 and make sure that they know that we are taking this concern that they have seriously and that they've been heard and that they understand that this might be a multi-step and a multi-visit process. I think you said this was an annual wellness visit where this came up. So I think also setting the stage to let people know, it might take some time for us to get all of the information and all of the touch points. That would be helpful.
And that's what we did. I think in this case, this is a great example of an opportunity where it deserves a dedicated visit or visits to follow up on this. So in this case, this woman would come back for a secondary evaluation. Goal is to empower physicians, primary care physicians, to know what the next steps are. order those cognitive lab screens, do your additional evaluation. If you detect that there's significant changes that warrant further evaluation, get your brain imaging. Make sure she's using her CPAP. In this case, they get to come back and bring their whole suitcase full of medicine so that we can go through and make sure there's nothing else going on. She couldn't hear too well, so she was going to wear her hearing aids next time too. So that's important, that you're maximizing all the functional sensory, optimizing her other medical conditions, so that when we go on to do further evaluations, we've eliminated these other barriers that may be impacting.
So I want to add one additional piece there to the conversation, and that's about working with her about how far she wants to go right now with the evaluation, because she may be reassured by the negative simple screen, but she may not be. And so if she continues to be worried, I would want to ask her quite a bit more about what she is worried about, because sometimes cognitive complaints come from being preoccupied with a stress situation that doesn't surface until you sit down and ask about, is there anything going on with you that might be affecting what you're thinking about and what you're concerned about? But let's also take this opportunity to point out that first stage screeners, that means kind of a broadly applicable kind of screener like the mini-cog, is pretty simple. It isn't perfect, but it's a pretty good, like, think of it as kind of a core sieve for identifying people who may have more serious cognitive impairments. But plenty of people who do have impairments will score normal on the mini-cog, especially if they have high levels of education and have been using their minds in their careers. So more detailed cognitive testing might just be a more difficult screener that you can use in your practice, such as the Montreal Cognitive Assessment and others of similar type. But I like to really partner with the patient to ask, how far do you want to go with an evaluation? Our choice is to just keep an eye on this. We can either evaluate in more depth now, or we can just keep an eye on it and watch. Okay. So, Andrea, you have a case for us today, too.
I do have a case, and it's one that I've seen many times. So this is a gentleman who is in his 70s and was living a fairly active lifestyle. He lost his spouse in the past couple of months, and after a golfing outing, a golfer, he had a fall. And he presented to the hospital, and while in the hospital, received a diagnosis of dementia. So he was confused during his hospital stay, disoriented, difficulty following directions during therapy. And he now is been discharged and is learning about this diagnosis that he received and is following up with his primary care provider. What do we think about this diagnosis that was received around this hospital stay, and how might we approach a conversation with this individual?
Well, Andrea, I think this is a not uncommon situation where we see seniors that maybe not have any detectable cognitive impairment go into a hospital setting, have different medications, not be sleeping, have underlying medical conditions going on that affect their cognition, and they're really delirious in the hospital setting. So my first question, my first thing was this true? Is this dementia? Is this delirium?
Right.
And differentiating between that. And knowing that this absolutely deserves further evaluation when people are discharged from the hospital, and almost everyone will improve somewhat when they get discharged. So I think it's very difficult to make a diagnosis of dementia in the hospital because you're not in a normal state. Now, that being said, oftentimes people have significant cognitive impairment pre-hospitalization that has not been recognized. And so this is a particularly important part. Our hospital system right now is prioritizing this. People that are detected to have cognitive impairment in the hospital need further cognitive evaluation. Right.
I think we have good data to show that first diagnoses of dementia in a hospitalized patient are often wrong, and often wrong because of the issue of confusion. But on the other hand, let's all reflect briefly on the fact that people who become delirious with relatively little physiological insult in the hospital when hospitalized. They're not on a lot of drugs. Their illness level is not severe or critical. Those patients with lesser physiological stressors in the hospital are likely to have underlying cognitive impairment. And that's where a lot of the work is going, is into what are the best ways to detect that earlier stage. But for our points, our perspective today, I think the take home is that not everybody with a dementia diagnosis made in a hospital is going to turn out to have dementia
Right.
a few months later. They may recover cognitively, but they still warrant tracking and follow-up, I would
Right.
say.
Absolutely.
What do you
Yeah.
think, Sue, about the longevity of that tracking? I think someone gets home and we're expecting this, and patients themselves too, like we want this immediate return to normal, to how I was, as an active individual. I was golfing with my buddies every week. I had this life. What are we thinking about in timeline and helping this person understand how long this monitoring may need to go on?
I think that depends in part on age and the rest of the patient's health status. So, we can't forget that most dementia occurs in older adults,
Right.
and as we know from basic gerontology, the older people get, the more different they are from one another.
Yes.
Right? The greater the individual variability. And so what that means is I think in terms of weeks to months. When I'm looking at someone who was diagnosed in a hospital, I want to track them over a period of at least 6 months to see how they're doing. Because some will normalize, but that doesn't mean they don't have underlying vulnerabilities. They probably do. And we need to be aware of that and take that into account in our care. So, should we be measuring biomarkers in this patient?
Well, that's a great question.
What do you think?
Well, I think my proclivity would be to provide this ongoing assessment. And I'm also thinking about age as well, and to understand what their concerns and questions are. Because, as is not uncommon, unfortunately, sometimes people get this code affixed during the hospital and they're not notified. So this may be a brand new concept to this person, where the addition of the biomarker discussion could feel like quite a lot. And I think that I really like how you talked about this 6-month monitoring period, because we know that these acute confusional states can take a significant amount of time to clear. And it might not be on the order of weeks.
Right. Okay. So let's, yeah. Mary, any comments?
No, I just agree. I think you have to make your own diagnosis. This is as a primary care clinician, I would, take what happened in the hospital. I would do my own cognitive evaluation once the patient has normalized at this 3 to 6 month mark, and then determine, do I think I think they have dementia? One, because we wouldn't be doing biomarker testing unless we think people have mild cognitive impairment or dementia. So we've got to make that diagnosis first, and then the likely etiology, looking at the different causes, and so the biomarker discussion would be much further down the pathway,
Right.
in my thinking, and typically most primary care physicians would be absolutely involving a specialist at that point to make that decision.
When you come up with the question, should I be doing a biomarker test of some kind? That's a specialist question today. And I hope we'll come back to that a little bit more, perhaps in the next case. But before we turn to that third case, I want to mention the concept of what you might call cognitive wobble. Kind of back and forth, some fluctuation that it becomes more and more common in much older people, that they can experience trouble with cognition with lesser degrees of stress, physical stress, mental stress, emotional stress, relational stress. And so going back and forth between a little bit not so good and then very good the next day or the next week, this wobble is a kind of an indicator of, I should probably be concerned that this person has underlying conditions that may set the stage for worsening over time, and I should be paying attention and following this. So I have a case too. This is a different kind of case. This is a 52-year-old man who presents with his wife. She says that his personality is really different. He's become irritable, he's moody with the kids, and he says nasty things to her that he's never said before. He accuses her of being, well, I'm not going to say it on a public forum, but he's upset her enormously, and she's thinking about divorce. So she wants to know what's going on with him. Why is he doing this? And the teaching point from this case is this is a young man. This is a man who's not in the typical age range for onset of Alzheimer's disease. Alzheimer's disease can present at this age. In fact, my youngest verified Alzheimer patient with Alzheimer pathology was 28 years old. She had a non-familial form of disease, just to really kind of show you the extremes that can occur. So this man could represent an early onset case of Alzheimer's disease, but he has some very unique features. He's had a dramatic personality change. Wife isn't saying he's having trouble at work, but I probe. And yes, he is having some trouble at work. His boss is has brought him in for a counseling session that he's not completing his work as he was expected to do. She doesn't want to leave him unless this is going to be, unless she's forced to. They've had a committed marriage. It's been a good marriage, not a perfect marriage, but a good marriage. But she can't live like this anymore. Right. So she's really turning to us to figure it out. So as I mentioned, the age of onset is young for Alzheimer's disease, but it could be Alzheimer's. Could it be something other than Alzheimer's? Well, of course, there are many different kinds of brain diseases. And I think we have to be considering in his case, frontotemporal dementia. A different neurodegenerative dementia has different pathology and a different course, and it typically presents with behavior change or what appears to be a psychiatric disorder. Most commonly, it's depression. One such patient I had presented to his PCP with depression but failed antidepressant therapy. He then became psychotic and got a schizophrenia diagnosis before he saw a specialist, in this case me, and got a diagnosis with frontotemporal dementia, of which he died about 5 years later. So if this is an atypical dementia of the frontotemporal type, so because I specialize in this area, I wasn't going to make a referral to a specialist, but in a primary care setting, this is a prime case for a referral to a specialist in cognitive disorders, if you have one. Now, we hope that the neurologist that you have available to you in your practice is able to make a diagnosis, a differential diagnosis of dementia. This isn't always easy for every neurologist either. Right? Neurologists, if they haven't had a lot of experience with these kinds of problems, may not be confident either. But so this is a case where we might really seriously think about biomarker testing. Young onset, atypical, doesn't seem like Alzheimer's, but could be Alzheimer's. A very serious family impact here that could really permanently affect the future of this family if his wife gets a divorce, his future if she divorces him. But in any event, a problem like this needs to have a very careful diagnosis with a definitive answer. Right. And so biomarker testing in this case was done and did not show, he had an amyloid PET scan, and the amyloid PET scan did not show Alzheimer's disease biomarkers, namely amyloid. He also had an MRI, and in his case, that MRI showed frontal atrophy, which is typical but not universal. Now, one challenge with patients like this is that they don't necessarily perform terribly badly on the kinds of cognitive tests we do for Alzheimer's disease.
Right.
And so you have to just be alert. So let's talk a bit more about the role of specialists and how primary care clinicians can work most effectively with specialists. What do PCPs value when they are providing care for people living with dementia?
Yeah, and that's a really important part, Sue. I think in our primary care practices, sometimes I feel that they're afraid to open the Pandora's box to diagnose dementia because what do I do next? And that's certainly part of the work that I'm doing now. We want a team of people that we know, one, that we feel confident in making a diagnosis. We have our abnormal screen, perhaps on our mini cog. What's the next step? Do I know what labs I should do? Do I know the imaging that I should do? Do I have access to imaging where I can look specifically for with volumetric analysis, for instance, for hippocampal atrophy? Am I comfortable talking to my radiologist, reviewing a scan if I have concerns, like you in your point, Sue, with something that may be frontotemporal or atypical? Do I have that partnership? And can I have access to different types of care? Do I know a neuropsychologist? I know in my system it may be months until I have a neuropsychological evaluation. What do I do in the meantime? Do I have access to a social work, case managers? Do I know my community resources? Do I have a go-to person that can help patients, a patient navigator that can help me go through and point patients and family caregivers in the direction where they can get additional resources? And then, like this case, this third case, I need a neurologist where I can say, this is an emergency. This is an atypical type of presentation. I need a consult expeditiously. Our system just implemented e-consults, which I think is great. I mean, it's obviously I'd rather have the full neurological neurology consult, but many times I can decide what the next step in the process should be, and I can expedite care with access to a neurologist either by e-consult or in person.
So there's a message for specialists in this dialogue, I think, and as well as for primary care clinicians, and that is that this partnership is really important. And Mary, you work in I would say, a resource-rich environment. I think I would say that all of us have our primary work in resource-rich environments where that's not the case.
Right.
The thing we need to do is find somebody we can talk to who is a specialist, no matter where they are. And this may be kind of a long distance consult too, that is done by email or by telephone, but find a specialist who's willing to partner with you as a primary care clinician, and have them explain to you what they're able to do for you, and explain to them what you can do and what you can't do, and how you need their help. So we love this idea of having a multiplicity, a variety of channels for communication between primary care and specialist clinicians in cognitive disorders. A short curbside, brief e-consult. I think we're using more and more e-consults everywhere now. And the more we tailor them to be able to provide the answers we need and the relationship that we want, I think the better off our patients are going to be. But we both have, on both sides of this dialogue, we need to be clear about what I can do, what you can do, what we can do together, and what other resources are needed to help this patient and family.
You know, Mary, you said something that's so important, which is this is an emergency. And I think we need to remember we're all subject to all of the social norms and biases that work through our society. And providing a 52-year-old a diagnosis of FTD or early onset Alzheimer's is gut-wrenching. And oftentimes, I think, we know folks with FTD have significant delays in diagnosis. And a lot of that's driven by our own internalized adversity and this atypical presentation. And we're so fixated on cognition because so much great work has been done in Alzheimer's disease. But these behavioral and personality changes, and I think we're making a nice full circle in terms of what is timely. And timely for this person is so quickly. We need to think about disability, access for them, if they do get a confirmatory diagnosis. And they may have a significant amount of life left. They might be very healthy. So I think that this is a great example of when we want to, yes, engage those specialty services and be agile. If they can get TDP 43 testing, that would be great. That doesn't exist in very many places. So this might be something that takes a lot of initiative and drive to push through some of those barriers that we know folks who have FTD experience.
So let's also not forget the fact that atypical cases and typical Alzheimer patients who have significant behavioral problems need something usually more than primary care. They may need psychotherapy for their families. And I'm thinking of my 52-year-old man whose wife and daughters needed and benefited so greatly from having an ongoing psychotherapeutic relationship, on again, off again, as things changed over time, but it really helped them interpret what was going on and not personalize it, and understand the disease in a much more holistic way, not blame themselves.
Right.
And the outcome was probably as the best we could have expected. He lived for 10 years with relative equilibrium for the family, not always for him, and then had a peaceful death of pneumonia in his early 60s. So I think that might be a good place for us to stop. I want to thank you both for being part of this today. It was such a rich conversation, and it was a delight to be with you and to share insights. Thanks so much.
Thank you.
Thanks, Sue.
Great
Thanks all for attending.